A very good evening, everyone. Myself, G. Arunagiri from Government Medical College, Tiruvallur. I'll be hosting this session today. I wholeheartedly welcome our AATRAL staff faculty, Dr. S. Lakshmanan sir, and our presenter for today's session, Dr. Megana ma'am. We can start the session. Over to you, sir.
So, with your exams coming up, I think CNS system will be a long case. So, I cannot be giving you a lot of info now, just a few days before the exams. Just try to give you some informations, the common questions asked, and help you just get through there. We'll straight away go to the presentation.
Good evening, sir.
Good evening.
So good evening to one and all present here. My name is Megana from Tabor Medical College and Hospital. So today I'll be presenting a case from CNS. Patient details: name Mr. Vasu, age 60 years, gender male, who is working as a tailor and residing in Tambaram, is a right-handed individual. Presented to the emergency department with chief complaints of inability to move the right upper and lower limb for the past 1 day, deviation of angle of mouth to the left side for the past 1 day, and slurring of speech for the past 1 day. History of presenting illness: patient was apparently normal until yesterday morning when he woke up around 6 a.m. and had complaints of inability to move the right upper and lower limb, which was sudden in onset and progressive. Initially, he had difficulty in buttoning his shirt and difficulty in gripping his slippers. By evening, the weakness progressed and he had difficulty in combing his hair and squatting and climbing upstairs. Patient developed deviation of angle of mouth to the left side, which was sudden in onset and was associated with difficulty in chewing food and rolling of saliva. The patient developed slurring of speech since yesterday morning, which was also sudden in onset, but he was able to understand commands and he used appropriate words while responding to these commands. Negative history: patient is able to lift the head and roll over the bed. He has no complaints of involuntary movements, muscle pain, cramps, or twitching. Patient is able to perceive clothes and differentiate between hot and cold water while bathing. He is able to walk normally without any unsteadiness in the dark and has no tingling or numbness, root pain, or girdle pain. He had no episodes of loss of consciousness or alteration in sensorium, delusions, hallucinations, or behavioral disturbances. He had no history of seizures or transient loss of vision. Patient is able to see clearly and perceive smell and has adequate eye movements. He is able to feel sensations over the face and is able to close the eyes. He is able to hear clearly and maintain balance and has no signs of tinnitus or vertigo. He is able to swallow normally without regurgitation and has no change in voice. He is able to move his neck and roll the tongue normally. He is able to eat without spilling food and can walk steadily in narrow paths without swaying. He has normal bowel and bladder movements without incontinence and no sweating, disturbances, or palpitations. There is no history of fever, vomiting, stiffness of neck, or trauma to the head and spine. Past history: patient is a known case of hypertension for the past 5 years and is not on any medication. No history of similar episodes in the past. No history of diabetes, coronary artery disease, rheumatic heart disease, asthma, epilepsy, TB, HIV, syphilis, or malignancy. No history of bleeding or clotting disorders. No other significant illness. And no history of previous surgeries or no history of previous or any significant drug intake. Personal history: patient takes mixed diet. He has normal bowel and bladder movement. History of alcohol intake for the past 20 years. No history of sleep disturbances. No history of smoking or drug abuse. Family history: no history of inherited bleeding disorders, sickle cell anemia, or other stroke syndrome. No history of stroke in the family. Summary: a 60-year-old hypertensive male, Mr. Vasu, presented with sudden onset of weakness in the right upper and lower limb, slurring of speech, and deviation of angle of mouth to the left side, which progressed over the past 1 day. history suggestive of UMN type of facial nerve involvement. No history suggestive of sensory deficits. No history suggestive of other cranial nerves, cerebellum, or brainstem involvement. The history is suggestive of acute onset of focal neurological deficit, probably of thrombotic etiology with a lesion at the level of left internal capsule due to a thrombus in the left middle cerebral artery.
So I am not interrupting you with the summary. Till then I was quiet because it might cause some tension, but you cannot expect the same in your exams. Now we'll go back to the first slide. We will just try to see what can be improved, what will be the expectations. The flow has to be continuous. Do not stop anywhere. That will be better. So the chief complaints is inability to move the right upper limb and lower limb for the past 1 day, which is suggestive of one side of the body, where you can put it as hemi. It could be paresis or plegia. Paresis where he is able to move but not with full power. Plegia is complete absence of movement. Deviation of angle of mouth could be suggestive of your 7th cranial nerve. Slurring of speech could be because of 7th cranial nerve or 10th or 12th. So this all happened within 1 day. So it is an acute event. So what are the possible acute pathologies? If you say that it is vascular, infectious causes, demyelination, and trauma. So at the onset itself, if your chief complaint is very clear like this, you will be able to format the diagnosis in this format. So now going to the next, presenting history of illness. Next slide. So whenever you ask for the history and take it down, put it down in the patient's words. We should not use our technical terms. So never write it as weakness. Always say it as inability to use right upper limb, inability to use left lower limb, whatever it is. Make use of the word inability. Then, rather than saying directly the patient was unable to do, what you can do is, how did you notice that you are not able to use? Usually you have to ask for the narration. What happened? Sir, I tried to reach for the glass. I was not able to do. This is how you have to ask and report. So the patient woke up at 6 a.m. He tried to go to the restroom. He tried to get down from the bed, but he found that he was not able to move his right lower limb. When he tried to mobilize that, then he noticed that he was not able to use his right upper limb. Like a narration, story narration, it has to be. You should not cut short the story and just give the facts. Examiners usually like it to be a story because these events make it more reliable. So our patient has right upper limb and lower limb weakness. This was the first symptom. Next one is he has deviation of angle of mouth. So what we have to notice here is all the symptoms have not happened within a given moment or a second. First one event has happened, after 1 or 2 hours another event has happened. So one by one, with a few hours gap, but within a single day or two. So how is this history important? To identify the nature of stroke, the pathology behind the stroke, this history will be very important. So we all know it could be either hemorrhagic stroke or ischemic stroke. In ischemia, it could be, the pathology could be because of a thrombosis or an embolic event. So to differentiate between a thrombotic and embolic event, this sequential involvement, that is one history followed by the other, one event followed by the other within few hours. This sequential event is classical of a thrombotic stroke. In case of an embolic stroke, all the clinical features would have presented in a given time. Maximum deficit would have happened within a given time. All this weakness, slurring of speech, drooling, every complaint would have happened within 1 hour. Whereas in case of thrombotic stroke, it will take 1 hour, 2 hours to develop the next symptom. That is what we call it as evolving stroke or a step ladder pattern. So if this is going to be ischemic stroke, the pathology is most likely to be thrombotic event. So that is why taking proper timing of the events, clinical feature is important. So the temporal profile, that is the technical term we give. Right from the beginning till date, how the events have developed. When did he notice, while doing what work he noticed all those symptoms is important. Next, are the symptoms remaining the same intensity or is it worsening? That also matters. If all this is going to happen within 1 day, this is most likely going to be stroke. If it is happening over 5 days, 10 days, then the other etiologies can come in. Apart from stroke, you can have demyelinations, you can have malignancies. All these will happen over a period. So as I already told you, acute events, the 4 etiologies is possible: stroke, demyelination, infection, and trauma. So if it is going to happen within 1 day, most likely it is stroke. So now this alone is not sufficient. How we are going to elicit the history is important. So there's proximal muscles, distal muscles. Proximal muscles in the upper limb are inquired by asking for whether he is able to wear his shirt, comb his hair. The distal muscles are asked by asking for buttoning of shirts, mixing of food, writing with pen. In the lower limbs, proximal muscles are inquired by asking whether he is able to climb stairs and get down, able to sit down and get up by himself. The distal muscles in the lower limb are evaluated by asking the history for their ability to hold on to the slippers, gripping of the footwear. If that is not possible, the distal muscles are affected. Why proximal, distal? Why should we ask for all these things? We should localize the structure involved, whether it is a UMN type of lesion or a LMN type of lesion in the corticospinal tract. Usually corticospinal tract involvement causes weakness. Apart from that, you can have weaknesses due to lower motor neuron type of lesions also. So differentiate between these two. We ask for this weakness pattern, how the bulk is, how the tone is, any other involuntary movement you see. So in this patient, you have asked very well about the weaknesses, inabilities. You have asked about the power of the patient. But one more thing what you could have added to the history here is about the bulk. Did you see any wasting of muscles, thinning of muscles, thinning of limb? That question can be asked here to ask for the bulk. Next, for tone, what we could have asked here is heaviness of limbs or stiffening of limbs. That would have been useful to say whether it was spastic type of weakness. If it was a flaccid, very flail, then it is most likely LMN type of weakness. In the first thing that we spoke about bulk, in LMN, usually wasting will be severe. Whereas in case of UMN, wasting is usually mild, only over a period it develops. That's why we call it as disuse atrophy. In UMN, the patterns for bulk and tone we have seen so far. Next, coming to the power. If the corticospinal tract is involved, mostly the distal group of muscles are involved. For example, in this patient, if you see, buttoning his shirt, gripping the slippers is more difficult. Only later on he develops the proximal muscle weakness. In examination, maybe we'll be able to differentiate this much more. So after this, did the patient see any involuntary movements? Usually involuntary movements are seen in element type of weakness, not in a human type of weakness. Next, from this we can see it is a human type of lesion. Now, human type of lesions can vary anywhere from the cortex till the anterior horn cells. So, what is a human type of lesion? Upper motor neuron lesion. So, the upper motor, the motor they mean here is the motor nucleus in the spinal cord. Anywhere above the motor nucleus till the cortex, if there is a lesion, we call it as corticospinal, a human type of lesion. So where are the possibilities? Number one is cortex. Next, it can be in the corona radiata, internal capsule. Fourth is in the brain cell. Fifth is in the spinal cord itself before reaching to the anterior horn cell. A lesion in this pathway anywhere can produce a human type of lesion. LMN is from the anterior horn cell till the muscle. So what are the structures possible in between these? We start from anterior horn cell. Next is roots. After roots, it is the peripheral nerve. Peripheral nerve ends in a neuromuscular junction where the nerve and the muscle meets. That junction, neuromuscular junction, and the last place is muscle. A lesion anywhere in this region can result in a element type of lesion. Why I am explaining this in depth is the most common question asked is what is a human type of lesion? What is a element type of lesion? Track the human pathway, track the element pathway. So what are the points we are going to compare is bulk, tone, power. In the history, this is what we can make out. Only in examination, we can go further into reflexes and etc. Next slide. Next slide, please. So the negative history, do not always say as no history of difficulty in eye movement, no history of smell. Never take it as a negative. No. Don't keep using the words no. The examiner gets frustrated. Rather put it in a positive manner. So how we are going to give the negative history? We start from the motor or cranial nerves, whichever is. Usually it is better to start with the cranial nerves. Where is the cranial nerve history, negative history slide? I think it was a previous slide.
This one, sir.
Yes. Here she is able to, the patient is able to clearly perceive smell, which means first nerve, olfactory nerve, has adequate eye movements and good vision. Adequate eye movements talks about third, fourth, and sixth, whereas good vision talks about the second nerve. Able to feel sensations over the face is suggestive of fifth nerve. And one more point you can add here is able to chew, bite very well. That means the masticatory muscles are very good, which is the motor component of the fifth nerve. He is able to hear clearly. That is your eighth nerve. The seventh nerve, our patient has a lesion and therefore it is not being mentioned here. He is able to swallow normally and has a normal voice. This will talk about your 9th and 10th. Then comes your ability to move neck and move the tongue. This completes your 11th and 12th. So she has given me the history of all 12 cranial nerves in a positive manner. So when you are going to present this, obviously at MBBS level, what the next question will be, name the cranial nerves 1 to 12. This could be very, very simple basic questions, but that's where we struggle. So the first one is olfactory, second is optic, third is oculomotor, fourth is trochlea, fifth is trigeminal, sixth is abducens, seventh is facial, eighth is vestibulocochlear, ninth is glossopharyngeal, 10th is vagus, 11th is spinal accessory, and 12th is hypoglossal. The first two has no nucleus. the other 10 has nucleus. So if you are able to answer this 12 cranial nerves, these are the certain questions that can come through. Which has nucleus, which doesn't have. If they have nucleus, how many nucleuses they have? Is it having a pure motor function or pure sensory, or does it carry both motor and sensory? These are the kind of questions that you can expect once you name the cranial nerves. So this history gives me an entire outlook about the cranial nerves. He is able to eat without spilling food and can walk steadily in narrow paths without swaying. Is more likely suggestive she is giving a cerebellar history. When the patient has tremors, they will not be able to take the food to the mouth. So that is what she was talking about, spilling of food. Walking steadily in a narrow path is also suggestive of a cerebellar function. Since it is normal here, I assume the patient's cerebellum is not affected. Normal bladder and bowel movements, no sweating is suggestive of your autonomic symptoms. Next slide. The no history, fever, vomiting is suggestive of ruling out your infections, raised intracranial pressures, because these are one of the DDs for stroke. Next slide. Apart from this negative history, you should talk about no movements, involuntary movements present in the case, all these things. The past history, the common things that we see in a stroke cases, hypertension, diabetes, and coronary artery disease. Rarely, patients can have connective tissue disorders like lupus erythematosus, which can result in stroke. So apart from that, there will be much significant. The most important point here is no similar history in the past, because stroke can occur again and again. That's why we have to ask for that. We should take that history because we have to find whether it was in the same territory or in a different territory. Now, the next slide. The personal history. Why does a diet matters in a stroke patient? If they are going to be a pure vegetarian, vitamin B12 deficiency will be there. That can result in a stroke-like presentation, corticospinal tract lesion. And this is 100% treatable. So diet is always mandatory. As for the diet history, if they are a vegetarian, B12 deficiency is highly possible. History of alcohol, smoking is very important because they can affect vessels and the heart as well. Family history is important. There are conditions where you can have stroke in a hereditary formats. Next. So summary, when you're done with all your history, you come to the summary. You pick up only the positive points. We had a right upper limb and lower limb weakness, slurring of speech and deviation of angle of mouth. So this all happened within 1 day. So patient is having right-sided weakness. Right-sided weakness means the corticospinal tract is involved, probably on the left side. Then slurring of speech and deviation of angle of mouth. If it was just only slurring of speech, it could be any of the 3 cranial nerves, 7, 10, or 12. But since there is associated deviation of angle of mouth, most likely it is the 7th nerve. So it should be on the left side. So there are no other structures involved here. Since the patient had step-by-step involvement, that can be suggestive of a thrombus. But before that, what is the structure involved here is corticospinal tract. The corticospinal tract, which level it is involved? Cortex, corona, internal capsule. At this juncture, we will not be able to tell. Most likely, it should be above the level of brainstem because the 7th nerve and the epiparesis is on the same side of the body. If it was on the opposite side, the brainstem is involved. It is outright proven. Since they are present in the same side, 7th nerve and the weakness, it is above the brainstem lesion. From the cortex to the brainstem, anywhere in between this place, your lesion can be there. Now, what is this lesion, sir? We know what structure is affected. The structure affected here is corticospinal tract. What could be the lesion, sir? Since it is acute, non-progressive, after that day, the second day, third day, fourth day, patient did not develop new symptoms. So it has happened only on that one day. So therefore it is non-progressive. Acute onset, non-progressive. This can be seen only in a vascular pathology. So when you take vascular pathology, stroke is the common disease. In stroke, we have hemorrhagic or ischemic. So the next question is what the examiner will ask you is, in history, how will you say it is hemorrhagic or ischemic? In hemorrhagic stroke, usually patient will have headache. Patient will have vomiting. Patient would have done heavy work on that day. Patient would have had some stress. These factors would have precipitated the bleeding. These are characteristic for a hemorrhagic stroke. I repeat, headache, vomiting, giddiness is also possible. Heavy work or stress would have precipitated the bleed. In case of a thrombotic ischemic stroke, usually it is on waking up in the morning. In hemorrhagic stroke, they develop it around 10 o'clock or 3 o'clock in the afternoon. Usually after the day begins, they develop hemorrhagic stroke. Whereas for an ischemic stroke, usually on waking up, they find this weakness. Apart from that, there will not be much of a finding. Now, in ischemic stroke, there are two variants. One is embolic, the other is thrombotic. If it was thrombotic, as in this case, symptoms would have evolved one by one with a few hours gap, which is called sequential involvement or stepladder pattern of involvement. There is a question asking why it is very common in the morning. Your sympathetic activity, your parasympathetic activity differs in the morning. What is a thrombotic involvement is, there is an atherosclerotic plaque in your vessel, which is building up over a period of time. On that particular day, the sympathetic response would have been not sufficient. The vessel would not have dilated. The vessel would have remained narrowed. Therefore, the blood supply to the brain would have reduced, resulting in stroke. This is the most possible reasons. Next. In a thrombotic stroke, as I said, there will be a sequential involvement. In an embolic stroke, usually all the symptoms will happen at one go. The next most important history is patient would have had seizures. Having seizure is classically suggestive of an embolic type of stroke. The next important thing is within 2 or 3 days, the patient will spontaneously recover in case of embolic stroke. Whereas in a thrombotic stroke, the weakness will remain the same. There will be no improvement. In a embolic stroke, the improvement will be spontaneous, even without medications. This history helps you to differentiate between thrombotic and embolic. So in our case, it's acute onset. After the first day, there are no new symptoms on the second or third day. So this is most likely to be non-progressive. Acute non-progressive lesions are vascular. Since the patient is having a weakness on waking up with a prior history of hypertension, more likely to be ischemic stroke. Since the patient has developed weakness sequentially, it is more likely to be thrombotic rather than embolic. So now, this is how we have put it. Now, then we have to talk about the circulation, the vessel involved. We have two circulations, anterior circulation, posterior circulation. Anterior circulations, only you will have weaknesses and cranial nerves on the same side. In the posterior circulation, they are likely to be on the opposite side of the body. That is what we call it as crossed hemiplegia. cranial nerve involvement will be on one side, weakness will be on the other side. So, other symptoms which can help you to differentiate between this anterior and posterior circulation is, in posterior circulation, we call it as 4 Ds. First D is dizziness, second D is diplopia, vision difficulties. Third D is dysphagia, difficulty in swallowing. Fourth D is dysarthria, slurring of speech. In this, you can have the 10th and 12th nerve and 7th also. These 4 Ds, if they are present, at least 1 or 2 out of these 4 Ds can suggest a posterior circulation involvement. Anterior circulation is usually more of weaknesses and 7th cranial nerve palsy. 7th cranial nerve palsy can happen in anterior circulation also, posterior circulation also. How to differentiate, sir? As I told you, if the weakness is on the same side of the facial palsy, it is most likely anterior. If it is on the opposite side, it is to be posterior. Another point which can help you differentiate is, if the brainstem is getting affected and as a consequence 7th nerve is being affected, an element type of weakness of 7th nerve will be seen. When the brainstem is involved, element type of 7th nerve palsy can be seen. In case of anterior circulation, human type of facial nerve palsy can be seen. So, in this case, if you see, the weakness and facial nerve involvement is on the same side and most likely a human type. Therefore, it is most likely to be anterior circulation. So, what is the vessel in the anterior circulation? Anterior cerebral artery and middle cerebral artery. The vessels for the posterior circulation is vestibular and basilar. So, anterior cerebral artery, middle cerebral artery. Now, how to differentiate between these two circulations based on the symptoms? In anterior circulation, anterior cerebral artery involvement, your leg involvement will be more. Patients' bladder complaints will be there. Whereas in middle cerebral artery involvement, the upper limb and lower limb involvement will be equal. Bladder involvement will be very rare. This is the point that differentiates between anterior cerebral artery and middle cerebral artery. In this case, if you see, there is no bladder involvement. There was no particular insistence on difference in the weakness of upper limb and lower limb. So this is where we should have asked whether both upper limb and lower limb weakness is equal or one is superior than the other, because it would have helped us choose the territory involved. If the lower limb was involved predominantly, it is likely to be anterior cerebral artery. If upper limb and lower limb are equally involved, it is most likely to be, or if the upper limb is involved more than, to put it better way, upper limb is involved more than the lower limb, it is likely to be middle cerebral artery. Now, the degree of involvement, we will confirm it with the examination. As at this stage, it is an anterior circulation involvement. It could be mostly MCA, second is ACA. I have been getting lots of questions. I'll definitely answer it towards the end. So this is how I want you to conclude a case. So acute onset, non-progressive, focal neurological deficit. Probably the structure involved is corticospinal tract, anterior circulation, a corticospinal tract. Probably it is a ischemic stroke of thrombotic type in the anterior circulation. The level of lesion, internal capsule, we need not say at this level, we can say it at the examination. Artery, we can say it as middle cerebral artery, it will be safe. Usually they keep only middle cerebral artery lesions for you, not anterior cerebral artery. So I'll repeat it. Acute onset, non-progressive, focal neurological deficit. involving the corticospinal tract, which is likely to be a stroke of ischemic type, in that it would be a thrombotic type involving the middle cerebral artery of the anterior circulation. This will give a clear idea of your knowledge to the examiner. So at this level, we complete the history. So for the questions asked so far, I'll try to answer at this level itself so that I will not confuse with examinations. So for a posterior circulation, 4 Ds: dizziness, diplopia, dysphagia. Why facial nerve? Sir, the facial nerve nucleus is once. If the brainstem is going to be affected, facial nerve can be affected. The other possibility is this nucleus gets information from the cortex. If that tract is affected, you can get facial nerve involvement. In the cortex, the representation for the face is more. So therefore, once again, facial involvement is expected. The homunculus representation in the cortex is very, very important. The medial side of the cerebrum, you have the representation for the leg. On the cortex, in the lateral side, your trunk, then comes your hands. So based on this, in a cortical lesion, you can have facial involvement. Yes, in an anterior circulation, your facial nerve lesion lies in the same side of the weakness. How to differentiate between cortical and subcortical involvement? When there is a cortical involvement, patient can have seizures. The upper limb is more involved than the lower limbs. Apart from that, there are few more sensory lesions that the patient can have, which we'll see in the examination part. The sensory cannot be spoken of here. When it is in the subcortical, most likely the upper limb and lower limb involvement will be equal. This is the main difference. In a cortical lesion, upper limb involvement will be more than the lower limb if it is the MCA. If it is the ACA, lower limb involvement will be more than the upper limb. This is called differential weakness. When there is a differential weakness, it has to be the cortex. When the upper limb involvement is equal to the lower limb, it has to be in the subcortical region, especially the internal capsule. Based on this, you can localize the history itself. Here we did not compare the weaknesses. That's why I didn't want to put the levels. Otherwise, if you had compared and give me a history, it would have been easier. So whenever there is a difference in the upper limb and lower limb, we call it as differential weakness, which is suggestive of cortical weakness. If the upper limb is more, it is likely to be MCA. If the lower limb is more, it is more likely to be ACA. In posterior circulation, cranial nerves involved are element type, sir. Yes, most of the time when the posterior circulation is involved, the type of cranial nerve involvement is element. So with keeping the time in mind, I would like to move on with the examination. Go ahead, doctor.
Examination. General examination. Patient is alert, conscious, and oriented to time, place, and person. Is moderately built and nourished. Afebrile. No pallor, ictus, cyanosis, clubbing, pedal edema, or lymphadenopaty. The patient is a right-handed individual. Neurocutaneous markers. Markers like markers of tuberous sclerosis, like adenoma seditium, shagging patches, ash leaf macules are absent, and other markers of neurofibromatosis, von Hippel-Lindau syndrome, Sturge-Weber syndrome, ataxia telangiectasia, spina bifida, birthmarks nevus, and pes cavus for Friedreich ataxia are absent. Vitals: pulse 80 beats per minute, normal in rhythm, volume, and character. no radioradial or radiofemoral delay, no apex pulse deficit, condition of vessel wall is normal and all peripheral pulse is felt. Blood pressure 170 over 110 mm Hg measured in the left upper limb with the patient in sitting position. Respiratory rate 14 per minute, regular and abdominothoracic type. Temperature 99 Fahrenheit measured in the axilla. JVP not elevated. Higher mental function, consciousness is intact, oriented to time, place, and person. Speech, slurring of speech present, but no aphasia, dysarthria, or dysphonia. Memory, immediate memory, retention, and recall, recent and remote memory are intact. No delusions and hallucinations are absent. Emotional liability is normal. Motor system, bulk, inspection and palpation, bulk is normal in both the limbs. Measurement, arm measures and forearm measures are equal on both sides. Similarly, in the lower limb, mid-thigh and mid-leg measurements are equal on both sides. Tone, in the upper limb, right side spasticity is present, left side is normal. Lower limb, right side spasticity is present and left side is normal.
Megana, give me a
Neck
moment.
muscles are good.
We will cut down the examinations into short gaps so the discussion will be easier. If it will be difficult, go to the general examination. I can see a lot of discussion going on about the sympathetic activity, early morning wake-up thrombosis. Forget about that. They are not going to ask you on that. Early morning on waking up, you are most likely to have thrombotic stroke. This is due to the mismatch between the sympathetic and parasympathetic. Leave it at there. Okay. Coming to general examinations, consciousness and orientation is very important because if it is going to be a hemorrhage or a huge, massive stroke, ischemic infarct, patient can be disoriented. So apart from that, pallor, icterus, cyanosis, is it a routine formality? No, definitely not. So how is pallor related to stroke? Yes, if the patient is going to have anemia, the patient is possibly likely to have any secondary diseases like SLE, can have thyroid, vitamin B12 deficiency, as I told, and therefore that could be the cause for stroke. Icterus could be because of jaundice. This jaundice can be from the secondary to your malignancies in the liver that had spread to the brain as the metastasis can result in stroke. Cyanosis, clubbing. So all of this have a reason. They can have an impact in neurology. So these questions are important. Next, why the handedness of the patient is important? Only then you will know which is the dominant side of the brain. Fine. Next. Next slide. Neurocutaneous markers, I think only in the MD level they'll be exaggerating so much. It is good that you have come up with so much. It could be very helpful for the other people. Nice you have so much findings. Markers. You can put it in a general word. Neurocutaneous markers are absent. And what the next question will be, what do you look for? What is a neurocutaneous marker you are expecting? Then maybe you can answer as tuberous sclerosis and neurofibromatosis. To your level, I think it will be more than sufficient. One neurocutaneous marker which can cause stroke is Sturge-Weber syndrome. The other one is ataxia telangiectasia. So these two also you can mention, because if you are going to give a detailed history about something that we do not come across very often, you are in trouble. So mention it as a neurocutaneous marker is absent. If the examiner asks you what did you look for, tuberous sclerosis findings like adenoma, so and so, neurofibromatosis findings, Sturge-Weber and ataxia, they'll be quite impressed at this level. Next slide. Next slide, please.
Vitals of the next one, sir.
Vitals. Vitals is very, very important. The pulse examination is important because your regular rhythm is important. If the patient is going to be having irregular rhythms, it is probably suggestive of atrial fibrillations or other. It can be suggestive of atrial fibrillation or other conduction defects of the heart. If you can find that irregularity, the next suspicion is whether it is cardioembolic stroke. So the examiner will be very particular about your pulse to pick up this cardioembolic stroke. Then is your blood pressure. The blood pressure, usually it is very high in case of hypertensive cases. Finding this is important because in the management varies. If it is going to be a hypertensive bleed, you have to reduce the BP immediately. If the patient is going to have stroke, you have to wait for 24 hours and then only start reducing. That is the major difference. So blood pressure is important. Respiratory rate, why it is important in the case of neurology, sir? The respiratory center is present in the brainstem. If the brainstem is going to be affected, the pattern of respiration can change and therefore the respiratory rate can vary. Apart from this, the most important reason why you look at respiratory rate is when there is a massive stroke, it can result in herniation. Herniation can cause raised intracranial pressure. Raised intracranial pressure will give you 3 clinical manifestations, the so-called Cushing's triad. What are they? Bradycardia, increased blood pressure, muffled heart sounds, or respiratory breathing patterns. So, respiratory pattern, blood pressure, and pulse, these 3 things help you to identify a raised ICP condition of the brain. I once again repeat, Cushing's triad. Reflex is different. Cushing's triad. There will be bradycardia. There will be hypertension. Respiratory rates can vary. There will be differences in that. Now, you're coming up with many mechanisms, why it is happening, reasons. I think before the exams, that will not be very good if you're going to go too much into the explanations. Swallowing center is your 9th and 10th. So it is in the medulla. So next slide, please. Higher mental functions, memory is unconsciousness is usually sufficient. We need not talk much about it. Only in the MD and DM levels they ask you. Even the delusion, hallucinations, emotional ability you can ignore, not required. Maybe if you tell that, you will land up in trouble. They'll ask you to define delusion. They'll ask you to define hallucination, illusions. Consciousness, orientation, speech. Speech is more suggestive of the language. Then memory. When I talk about speech, this is what I want to mention. There is a lot of difference between speech and language. Language is communicating your thoughts to the opponent. This communication may be in the form of speech or sign languages or expressions. So language has different ways of expressing your thoughts. One among them is speech. So when you look for speech, you say it is aphasia or dysarthria. Most commonly, languages, if they are totally absent, they are most likely to be cortical lesions. Only speech is affected, slurring is there. It is once again likely to be cortical, which is the 7th nerve specific or even in the brainstem. Aphasia is less likely to be brainstem. That is what I am trying to say. Aphasia is less likely to be brainstem. Dysarthrias can be there in both brainstem as well as the cortex. So at this level, these 2 things, language and memory, is enough to mention for higher mental function. The next slides. Spinomotor examination. That heading will suit better rather than motor system. Spinomotor system. Go ahead, doctor.
Spinomotor system examination, bulk, inspection and palpation, normal bulk on right and left side. Measurements. Measurements are equal on both sides in the upper and lower limb, measured at the mid-arm and forearm levels, mid-thigh and mid-leg levels. Tone, where the tone is spastic in the right upper and lower limb. It is normal in the left upper and lower limb. Power, the neck muscles on the right and left sides have good power. In the upper limb, the shoulder, elbow, and wrist movements, the power is 3/5 on the right side, and power is 5/5 on the left side. And hand grip and small muscles of the hand are weak on the right side, and they have good power on the left side. Trunk muscles, right side weakness is present, and left side it is good. Beaver sign is absent. Lower limbs, movements at the level of hip, knee, ankle. Power is 3/5 on the right side and 5/5 on the left side. Small muscles of the foot are weak on the right side, and they have good power on the left side. Reflexes. In superficial reflexes, abdominal reflex is absent on the right side, and left side it is present. Deep tendon reflexes, biceps, triceps, supinator jerk, knee jerk, and ankle jerk. On the right side, it is exaggerated, and on the left side is 2+, which is present. And clonus is absent. Primitive reflexes, Hoffman's and Wartenberg sign are absent. Coordination is normal. Gait, circumduction gait is present. Involuntary movements like athetosis, hemibalismus, chorea, dystonia, tremors, and fasciculations are absent.
We'll come to this
Cranial nerve examination.
We'll come to this later. Usually, after higher mental function examination, cranial nerve should come. Once the nerve is done, then you'll go for the motor system. Okay.
Okay.
Fine. Now, come to the beginning. To begin with, as I already told you, what we are trying to do in this motor system evaluation, we are trying to say whether it is UMN type of lesion or LMN type of lesion. So we should know the differences. In a UMN type of lesion, bulk is expected to be the same. Only after 3 to 6 months, due to disuse atrophy, lack of usage, they will be wasting. In LMN, there will be severe wasting at presentation itself. Next, in tone, there will be spasticity in UMN type, flaccidity in LMN type. Next, your power. Power will be mostly in case of corticospinal tract involvement. In the upper limb, extensor group of muscles will be affected more. Distal group of muscles will be affected more in case of UMN type of lesion. In LMN type of, I have told you about the upper limb, the lower limb for a UMN type. Flexor weakness will be there in addition to the distal. The pattern varies in the upper limb and lower limb. Listen once again. In the upper limb, extension is affected more. In the lower limb, flexion is affected more. In both the limbs, weakness is more in the proximal, more in the distal than in the proximal. This finding helps you to say it is UMN type and not LMN. In case of LMN, how will the presentation be, sir? Both proximal and distal can be equal. More of proximal can be involved. Flexor, extensor, this prevalence will not be there. Both can be equally involved. So, for us to our level, we'll remember this alone. Corticospinal tract or the UMN lesion, distal muscles are involved more. In the upper limb, extensor muscles are affected more, that is anti-gravity muscles. In the lower limb, flexor muscles are affected more. We were talking about tone, the spasticity. The spasticity will be more. Tone will be more in the opposite group of muscle. In the upper limb, you saw there is weakness in the extension. So tone will be more in the flexor muscle because its power is unchecked. So you should not confuse. In upper limb, weakness of extensor, spasticity of flexor. In the lower limb, weakness of flexor, spasticity of extensor. Okay. Can you say what is spasticity presenter? In these times, you should know the definition. What is tone? How will you classify it further? Please go ahead.
Sir, tone, it can be classified into hypertonia and hypotonia. In case of hypertonia, there can be two types. It can be the spasticity or rigidity. Spasticity is when only one group of muscles is affected, and it is based on velocity and direction. And in case of rigidity, the entire group of muscles, both the agonists and antagonists, are affected, and it does not depend on velocity or direction.
So rigidity is mostly suggested to a extrapyramidal tract involvement. Spasticity is for the corticospinal tract involvement. Definition of tone.
Tone is the passive resistance felt by the examiner while examining the patient during passive movements. So it is the
anti-gravity muscles are flexors? No. When you want to lift your wrist, it is going to be extension. Okay, in the upper limb. Similarly, in the lower limb, it is going to be the flexor. Next. In these slides, if you see flexion and extension, both have been graded as 3/5. If that is the case, it is likely to be 11. So you should grade it as flexion individually, extension individually, abductor individually, adductor individually, lateral rotation individually, medial rotation individually. The scoring of power should be made individually for all these muscles, not as pairs. I hope
okay, sir.
in the next slides. Okay. So I assume the pattern of involvement in this the patient was more of distal and extensor in the upper limb and flexor in the lower limb. Okay. How to examine these muscles is very, very important. If I'm going to take these classes, I think it will take 1 or 2 hours time. So how did you examine for the flexion? How did you examine for the extension? How did you examine for abduction? All these comes very commonly. They will drill you in the motor system. Next, the MRC grading, this power 1, power 2, power 3, power 4, power 5. What is it? Explain.
Sir, zero power is no contraction, and grade 1 is flicker. Grade 2 is absence of movement, even when both gravity and resistance are eliminated. Grade 3 is patient is able to lift or move against gravity but not against resistance. Grade 4 is patient is able to move against gravity and against resistance, but the movements are still weak. Grade 5 is normal movement, it move against gravity as well as resistance.
Okay, very good. So now I'll try to give you the cliche in this important point in this. I cannot be telling for every muscle, but in a simple format. You will be able to identify 0, 1, or 5. The problem here is identifying a 2, 3, and 4 and defining it to the examiner. The confusion between 2 and 3. 2 is ruling out the gravity. The patient cannot do against gravity, but alongside the ruling out the gravity, he can do. 3 is against gravity. How to examine this, sir? If this is assume this is going to be the bed, you can keep the fingers like this and ask them to flex and extend. Lifting up and down in this format is against gravity. Doing it along the plane of the bed is for ruling out the gravity. Hope you get it. If this is the bed, this movement is suggestive of gravity movements. If you are doing along the plane, the X plane, then it is examining for ruling out the gravity. Now, coming to grade 4, sir, providing resistance. You will put 3 fingers, then you try to resist. Probably your left hand if you are examining a female patient. If it is a male, right hand will be sufficient. Okay. The previous slide. Previous slide. Upper limb. Exactly. The small muscles of hand. There is too much of examinations involved. But how do you examine this in your patient, doctor?
Sir, ask the patient to squeeze my fingers, sir.
That is practice.
All the muscles.
Hold our hands tightly. We can squeeze. Apart from that, if they ask you to do individually, it will be quite tough. So this method is more than enough.
Okay.
The next one, the lower limbs. How to examine the small muscles of the foot. Ask if you consider this to be a foot, ask them to cup it. Cupping of the foot, bringing all the toes together. If they are able to do it, the small muscles of lower limb is very good. If they are not able to cup it or bring the toes together, then you can suspect a small muscle weakness of the foot. Fine. Next, Beaver sign someone was asking. Beaver sign is to look for abdominal muscle weakness. You ask the patient to lie down. You keep the pencil or your knee hammer's rod structure exactly above the umbilicus. It should lie exactly above the umbilicus. So after this, you ask the patient to flex their neck and look at the foot. The umbilicus should not move more than 0.5 centimeter to 1 centimeter. It will remain in the same place. In case if the umbilicus is moving up more than 1 centimeter compared to the knee hammer that you have placed or the pencil you have placed, moving 1 centimeter further, then it means Beaver sign is positive. What does it indicate, sir? There is a differential involvement of the abdominal muscles. The upper abdominal muscles are spared, lower abdominal muscles are affected. This is what the Beaver sign will say. Beaver sign is not seen in a stroke patient. It is seen only in a spinal cord involvement. So therefore, Beaver sign you can ignore, not an issue. Go ahead.
Cranial nerve examination. First nerve.
Deep tendon reflexes.
Okay, sir. Deep tendon reflexes, biceps jerk, triceps jerk, supinator jerk, knee jerk, and ankle jerk. On the right side, it was exaggerated. On the left side, grade was +2. Normal reflexes were present. Primitive reflexes, Hoffman's.
What kind of a reflex is deep tendon reflex? Polysynaptic or monosynaptic? Deep tendon reflexes are monosynaptic. So they will ask you to differentiate between polysynaptic and monosynaptic. Superficial reflexes are polysynaptic. Deep tendon reflexes, you should know the root value. Biceps reflex, what is the root value, doctor? Can you say the root value for all the reflexes for everyone's information?
Yes, sir. So biceps is C5 and C6.
Okay.
Triceps C7, C8, and supinator is again C5, C6. Knee for the ankle is S1, S2, and knee is L3, L.
Ankle, I would like to keep it as S1, L5 and S1.
Okay.
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 Root value. The next question they'll come up is, what is the nerve supplying the reflex? Biceps is yes, you didn't expect that. So for biceps, it is going to be your musculocutaneous nerve. For triceps,
Radial. No.
nerve. Very good. For supinator,
Supinator also radial now, sir.
knee jerk, femoral. Ankle,
Yeah.
peroneal. Okay, fine. So these are the questions that are expected to come very often. Now, what are the grades of the deep tendon reflexes?
Sir, grade 0 is complete absence of reflexes. Grade 1 is weak reflexor. Grade 2 is grade 1 and grade 2 presence of normal reflex. Grade 2 plus is brisk, and 3 plus is exaggerated reflex.
How we can put it is grade 1 or sluggish present. Usually the ankle
Okay,
jerk
sir.
it has 1 plus. Okay.
Okay, sir.
Grade 2 is normal or equivalent to your knee jerk.
Okay.
Grade 3 is brisk. Grade 4 is exaggerated. In those cases, you can have clonus. When you have a clonus, you call it as grade 4. Grade 3, you can say either as brisk or exaggerated. You will say grade 4 when the patient has clonus. Now, how do you expect the reflexes to be in LMN and UMN?
Sir, in human type, the reflexes are exaggerated, sir.
Very good. In LMN, it can be normal or absent or 1 plus.
Okay.
Coming to clonus, what is clonus? Define clonus. How will you look for clonus? Where you can see clonus?
Clonus can be seen at the level of the ankle joints, sir.
You can see in ankle, you can see in the patella, you can see in the wrist. 3 places you can
Okay,
look.
sir.
It means there is a long-standing corticospinal tract lesion. That is all it says. Okay. The movement, the clonus activity,
Okay, sir.
activity should be at least 6 times to call it as sustained clonus. If it is 3, if it is 4, we can call it
Yes.
as sustained. Okay.
Okay.
The reflexes are all about your frontal lobe. I'm not going much into that. Hoffman's and Wartenberg's is usually suggestive of your pyramidal tract involvement. Okay. In view of the time constraint, we can move to the next topic. Next slide. Extrapyramidal gait is very, very important. What is a circumduction gait? Why the patient has circumduction in stroke? What is circumduction?
Sir, it is a dragging type of gait, sir, because both since there is weakness in the lower limb, for every step the patient takes forward, he'll have to drag the leg to bring it in front. So it creates a semicircle-like movement. So it's called a circumduction gait.
Semicircle like movement, that is the most
And
important.
also, He leans towards the normal side.
So we'll come from the history, we'll get examination, I'll get you there. As I already told you, in the lower limbs, flexor muscles are affected. Okay. So you will not be able to flex your hip. You will not be able to flex your knee. If you want to keep a step, you have to flex, get an elevation, then take a step forward. In our patient, flexing is not going to be possible. The next point, spasticity will be seen in extensor muscle. So because of spasticity, what is going to be happen? The muscle is going to be very stiff. It will be straight like a pole. When it is like a pole, they cannot flex once again. So to walk, what will the patient do is, they will rotate the leg, circumnavigate. The straight pole, it has to rotate. It cannot be flexed. That's why you call it as circumduction gait. The hip joint will be straight. The knee joint will be straight. The ankle will also be plantar flexed because dorsiflexion is not possible. That is why you have a circumduction gait in stroke. Another possibility is scissoring gait, which is usually seen in a chronic case. So circumduction gait should be sufficient. I hope I made it clear with your explanation in circumduction gait. It is your flexor weakness. You cannot elevate the leg, clear the foot. Therefore, to make space for the movement, the patient goes around, circumnavigation. Fine. Coming to the extrapyramidal movements, involuntary movements. I think if you say it is not there, that is more than enough. If they ask what are the movements you looked for, you can mention all these things. Then go ahead.
Okay. Cranial nerve examination. First nerve, sense of.
Cranial nerve should be before spinomotor examination in the order of presentation.
Okay, sir.
Cranial nerve.
Okay, sir. Cranial nerve examination. First nerve, sense of smell was tested using coffee and is present on both right and left side. Visual acuity 20 by 20 on both eyes. Field of vision and colored vision normal. Fundus examination normal. Third, fourth, and sixth nerve. Extraocular movements full and adequate. Both direct and consensual right reflex are present. Accommodation reflex present. Ptosis is absent. Nystagmus and Horner syndrome absent.
You need not mention Horner's.
Okay, sir. Fifth nerve, sensations over face and buccal mucosa are intact, normal. Motor, the masseter, temporalis, and pterygoids are normal. And corneal and conjunctival reflex is present. Jaw jerk is normal. Seventh nerve, wrinkling of forehead is present. Nasolabial fold is less prominent on the right side and prominent on the left side. Occipiter frontalis is good on both sides. And orbicularis oculi is also good. Orbicularis oris and buccinator muscles are weak side and normal on the left side. Taste sensation is intact in the anterior two-thirds of the tongue. Corneal and conjunctival reflex is present. Eighth nerve, Rani's test is positive in both ears. Weber's test not lateralized. Nystagmus is absent. Ninth and 10th nerve, uvula and palatal arch movements. Uvula is centrally placed and palatal arch movements are symmetrical. Gag reflex and palatal reflex are present. 11th nerve, trapezius and sternocleidomastoid functions are good on both sides. 12th nerve, there is tone is normal and there is no wasting of the tongue muscles. On protrusion, tongue is in midline and there is no deviation.
So we'll come to the first of the cranial nerves. The most common question they ask you in the exam is demonstrate reflexes. Please, before you go to the exam hall, at least go through a YouTube video. Unfortunately, I'm not able to demonstrate here as I don't have any patient. Look at the video, see how to demonstrate a reflex. If you can demonstrate all those 5 reflexes, it guarantees your pass. In a long case, it is the most essential thing to pass. So please do know how to do a reflex. To a hostel, people can do it with your friends so that you can correct yourself. The day scholars try to mobilize somehow or see online videos. Get it from me. Definitely they are going to ask you to demonstrate reflexes. The sense of smell with coffee, you should close one nostril and check on that and then on the other. Both should not be examined at the same time. All this visual acuity, everything is fine. Extraocular movements, if the extraocular movement is going to be affected, it is more likely suggestive of third nerve or fourth nerve or sixth nerve. When these are affected, it is most likely the posterior circulation. Midbrain area is affected. That is what you have to take it from here. But mostly in exam, you will not have such a case. The next slide. I hope you know how to look for pupillary reflex and accommodation reflex. In the sensory and motor for fifth nerve, this is well examined. In corneal and conjunctival reflex that you have mentioned here, it is a superficial reflex. You can mention it under superficial reflex column also.
Okay.
In the seventh nerve motor, this is our area of importance where the examiner is going to focus much. Wrinkling of forehead. You will stabilize the patient's forehead and then you will ask them to look up the ceiling. You will look for the wrinkles. If it is absent, it is likely to be UMN lesion. If it is, if the wrinkles are absent, it is to be LMN. If the wrinkles are present, it is to be UMN. Can you say why?
Sir, upper part of the face has bilateral innervation, sir.
Yes. So, usually there is a fibers coming from right side and left side to your seventh nerve nucleus in the brainstem. The nucleus has two portions, upper and lower portion. For that, when their nerves descend, they cross over and innervate on the opposite side. But this crossover happens in addition to the ipsilateral supply also, only in the upper part of the nucleus. In the lower part of the nucleus, only crossed supply is there, ipsilateral supply is not there. That is why, putting in simple terms, the upper face has bilateral representation, whereas the lower has only unilateral. That's why you have a element type having a loss of wrinkles. Other features suggestive of element type seventh nerve is Bell's phenomenon. Whenever we close our eyes as a normal phenomenon, when I'm closing my eyes, underneath the eyelid, the eyeball will be going up. Since the eyelid is covering it, this normal phenomenon you are not able to see. In case of a seventh nerve element palsy, that is the orbicularis oculi will not close. So the eyelid will be open. Therefore, when you ask the patient to close, the upgoing of eyeball becomes obvious. This is what you see in Bell's phenomenon. Bell's phenomenon is a normal process. Since there is a orbicularis oculi weakness, you are seeing it to the naked eye. Am I making it clear?
Yes, sir.
Bell's phenomenon is seen. It is a seventh nerve element type palsy. Okay. Apart from that, your whistling, sucking from straw, buccinators checking, all these will be going to be common in both. The sensory taste aspect is most commonly affected in element, not in your UMN. You will be bombarded with questions here. How is element and UMN differentiated? When there is bilateral element, bilateral UMN, how will you differentiate? What is a central facial paralysis or emotional facial palsy? That is a common question asked. Can you say what it is, doctor?
Sorry, sir.
Emotional facial palsy or the central facial palsy?
Sir, it is weak. It is weakness in facial movements. It is a supranuclear type of palsy.
It is a supranuclear type of element palsy. It is a supranuclear type of palsy. Seventh nerve palsy. Patient, when they are not aware of their activities, every function will be there. But when you ask them to do voluntarily, you will find the difference. You ask them to smile, that when they do something voluntarily, it will not be seen. They are doing it naturally, subconsciously, there will be no lesion. This is a central facial palsy. Why this happens is, it does not take the routine route of a facial nerve pathway to the nucleus. It has a different pathway. It does not pass through the internal capsule like the routine pathway. This fiber alone travels in an outside pathway and then goes to the seventh nerve nucleus. So that is the difference. Next thing you should know the difference between bilateral UMN type of seventh nerve and bilateral LMN type of seventh nerve. What is the difference?
Not sure, sir.
I didn't get you. As I told you now, Bell's phenomenon will be seen in LMN type of palsy. Then your emotional palsies can be visible. Third is cortex will be affected. Long track signs are less likely. Whereas if it's a bilateral UMN, is seen patient will not have Bell's phenomenon. This is a common question asked when you are discussing about seventh nerve. In a stroke patient for MBBS, seventh nerve will be asked very much. So be thorough with the anatomy, know how many nucleus are there, how to track the nerve, the divisions and all. So now we will not be able to do that. Going on, corneal reflex and conjunctival reflex, you need not mention in the seventh nerve. Then,
Okay, sir.
so there has been question. Okay, go on. I'll explain it in the end. 1 second. 8th, 9th, 10th, 11th, 12th. All these are most likely expected to be affected in a posterior circulation, not in an anterior circulation. They might ask you how to evaluate for a gag reflex. Demonstrate. First, open the mouth. Try to localize the uvula. With the gag, you will touch the pharynx. Pharynx on one side, on the other side. The first question you will ask is the patient is whether they are able to feel the touch, the sensation of touch. Next, it is obvious to you they will vomit. So when they are vomiting, it means that it is normal. If they are not vomiting, there is no nausea. That is when you will ask for the question, are you able to feel the sensation when I touched? They say no. 9th and 10th both are affected. That is an LMN type of palsy. So gag reflex you should know how to do. Tongue, how to look for tone. Put in a gloves, palpate the tongue. How to look for power? Ask them to touch in the cheek, your fingers. Give the pressure, exert the pressure. Ask them to touch against it. Maybe that will help you to look for the tongue power. Moving on to the sensory.
System, spinothalamic, crude touch, pain, and temperature are normal on both sides. Posterior column functions, fine touch, vibration, position sense are normal on right and left sides. Cortical sensations like 2-point discrimination, tactile localization, graphesthesia, and stereognosis are normal on both sides.
So some of you have asked me, sir, subcortical and cortical, how to differentiate? This is where the importance comes. the spinothalamic, the screw touch, pain, temperature, all these things are your primary or secondary sensory systems?
So screw touch, pain, temperature, and posterior column are secondary. Cortical is primary. Cortical sensations.
Okay. So where does they end? Where does the pain, temperature, fine touch and all end? Where does the cortical end? Pain, temperature, everything is mostly in the thalamus. Only a few fibers passes beyond that to the parietal. Cortical, everything starts from there. So basic point we have to understand here is, if the patient is not able to appreciate pain, temperature and touch, there is no point in examining cortical, because only after crossing the thalamus it has to go to the cortex. If the thalamic sensation itself, the primary sensations are itself affected, it will be very difficult to look at the cortical evaluation. Okay. So how to do 2-point, how to do tactile localization, graphesthesia. I think it will be a huge class. We'll cut it down. Sensory, they won't probe you much. Go to the next.
Cerebellar examination. Titubation is absent. Truncal ataxia, gait ataxia, or stance ataxia are absent. Nystagmus, dysarthria, intention tremor, and hypotonia are absent. Rebound phenomena is absent. Pendular knee jerk is absent. Tandem walking is normal. Finger nose test, nose test, and drawing of circle using the upper limb is normal. For the lower limb, heel shin test and drawing of circle using the foot is normal. Dysgynecokinesia.
There's a confusion here. Primary is your pain, temperature, and touch. Cortical is secondary. Go ahead.
Okay.
So these cerebellar lesions, only when there is a posterior circulation, you expect these to be involved. What is titubation? The head will be nodding. It is almost like a head nodding to and fro. Truncal ataxia. How will you expect them to do? You ask them to sit on the edge of the bed, put one leg over the other, support the hands. If they are able to maintain the trunk posture even after this, their trunk is normal. Stance ataxia, you ask them to stand, keep both the feet together. Patient has to look straight. If they look down, the vision will compensate. So I ask them to look straight, and if they are able to maintain the pose, no ataxia. If they come out, they fall, step aside, definitely stance ataxia is present. Nystagmus, you ask them to focus your fingers wherever they are moving. Rebound phenomena is, you ask them to flex the elbows against your resistance. When you leave, they have to stop it without hitting the face. That is rebound. Make sure you protect the face with the other hand of yours. One will be giving the resistance, other should protect the face. If you don't protect the face, they will raise questions. How you examine the patient matters. So in a rebound phenomenon, two things you have to focus. One is with one hand giving the assistance, other is protecting the face. Pendular knee jerk is to and fro movement at least 3 times. Tandem walking is 1 foot after the other. Never do tandem walking immediately. First ask them to walk in a straight line. If that simple test is not possible, no point in doing a tandem walking. If a patient is able to do a simple straight walking easily, you complex it by asking them to do the tandem walking. Once again, in a tandem walking, ask them to look straight, not down. If they are going to look at the floor, the vision will compensate. Finger nose test, lower limb heel knee test, everything is for your coordinations. So first, the simple level of examination is doing this, the fingertip touching this one. If they are able to do the simple evaluation, only then you will go for the complex. Fine. How will the tremors in a cerebellar lesion will be? When the patient is starting here, there will be no tremor. As they approach the object, that is when you will start having the tremors. This is very, very important. In a cerebellar tremor, when they start reaching for the object, there will not be much of tremors. As they near the object, the tremor will be very severe. When they are about to take a pencil, take the food, take a glass, on initiating the movement, there will not be tremor. As they reach the object, the tremor will be very bad. Even in this finger nose test, here there will not be much movement. As they get close to your finger, there will be severe movements. This is classical of an intentional tremor. Okay. This is what cerebellar science is all about. Next.
Autonomic nervous system is normal. Signs of meningeal irritation like neck stiffness, Kernig sign, Brzezinski sign are absent. Examination of the spine and cranium, no bony deformities, bruit, gibbous or is tenderness present. Peripheral nerves, no thickenings or trophic ulcers, wrist and foot drop are absent. Carotid bruit is absent.
Okay, good.
Examination of other systems, cardiovascular system, JVP normal, apex normal, no palpable sounds, heart sounds are normal, no thrills or murmurs heard. Respiratory system, chest symmetrical, no paradoxical movement, normal vesicular breath sounds heard, no abnormal or added sounds. Abdomen is soft, no organomegaly, no ascites.
Usually in an excitement after such a serious long examination, we will forget to note down or document examination of other systems. This will pull your leg down. I have made this mistake. So I repeat, don't forget to mention about examination of other symptoms. It is very, very important in a long case. Next.
Provisional diagnosis. A case of acute cerebrovascular accident with right-sided spastic hemiparesis and Human type of facial nerve palsy due to thrombotic ischemic stroke with lesion at the level of left internal capsule due to involvement of middle cerebral artery.
The internal capsule here because the power of upper limb and lower limb is equal. That is why it is internal capsule.
Equal.
Okay. I think since we discussed in depth in the history how to structure the diagnosis, I believe you will be comfortable here. We will not discuss much. Go ahead with the next. Now we have diagnosed the patient. What should we do next? That is what the investigation part is about. Differential diagnosis. Always don't give a fixed diagnosis. Be ready for differential diagnosis. The commonest thing we can talk about is metabolic disorders like hypoglycemia and hyponatremia. These 2 points will have a good value. The next is malignancies, space occupying lesions. The most important point is Todd's palsy. These 3 things, if you are able to say it as a DD, very well and good. Moving on to the next slides.
Investigations, complete blood count, coagulation profile, lipid profile, and non-contrast CT to rule out hemorrhage, followed by diffusion-weighted MRI, and carotid Doppler, MR angiography, ECG, and echocardiogram.
So the most important investigation here is CT brain plane. If the patient is coming to you within 4.5 hours, this is very, very important because it takes only 5 minutes to take a CT. If there is a bleed, you are not going to thrombolyze. If there is infarct and the time is less than 4.5 hours, you can thrombolyze the patient, provided there is no contraindications. The most important investigation in this list is CT brain. If the patient is going to come after 4.5 hours, he is out of window period, you can relaxedly evaluate for everything. And one more point is, even if he is seen in a window period, look for the pulse, look for the ECG, rule out the cardioembolic possibility. Management.
Endovascular procedures for clot retrieval or stent for stenosis, and thrombolysis can be done if patient presents within the golden period of 4.5 hours with alteplase, which is a recombinant tissue plasmogen activator. Dosage is 0.9 mg per kg. 10% of the dose can be given as IV bolus, and the rest of the 90% is given as infusion over 1 hour. And antiplatelets like aspirin started with a dosage of 300 mg, followed by maintenance of 150 mg. clopidogrel and statins can be given. In this case, patient is hypertensive and he is not on any medication, so antihypertensives should be started.
So, whether it is ischemic stroke or hemorrhagic na, except for reducing the BP, nothing else can be done much. For reducing the BP, you can give antihypertensives. Usually maintain it around 140 to 90. When it is going to be ischemic stroke, the first 24 hours, you will not reduce the BP. Only when the BP is more than 180 or 105, you will try to reduce it. Otherwise, in the first 24 hours of ischemic stroke, you will not reduce BP. Next, patients can have edema. So anti-edema measures can be given like mannitol or 3% NaCl. Third, in hemorrhage, you can expect seizures. So anti-epileptic can be given. In addition to these, in case of ischemic stroke, you have to give antiplatelets. Antiplatelets, if the patient is falling within 6 hours, then you can advise them, refer them for mechanical thrombectomy. That is the endovascular procedure she has mentioned here. Apart from this, you have to do echo and CV Doppler. Echo is to assess for your heart. Any thrombus is there or not, any cardiomyopathy is there or not, valvular problems is there or not. Echo is an important investigation. Next one is carotid vestibular Doppler, CV Doppler. The vessel from heart to the brain, anywhere along it can have atherosclerosis. Thrombus for a emboli from there can go and dislodge and get blocked in the brain. So looking for a CV Doppler is also important investigation apart from these things. Another management thing that has to be added here is physiotherapy. Limb physiotherapy. If the patient is having speech problem, speech physiotherapy. Swallowing difficulty is there, swallowing physiotherapy. So 9, 10, 11, 12 cranial nerves, 3rd, 4th cranial nerves, cerebellum, if all these are going to be involved, it is posterior circulation stroke, basilar or vestibular artery. If it is less likely only the 7th and the pyramidal tract, mostly it is the anterior circulation stroke. So that is in a nutshell. Don't say stroke all of a sudden. Go stepwise. That is what I would like to stress in the end of the presentation. Whether it is acute or chronic, most likely it is acute. Non-progressive, because all happened within one day. The consequent days you wouldn't have new findings. Next, acute non-progressive, most likely the structure is vascular, anterior or posterior circulation. Next, if it is going to be UMN type or LMN type, UMN type where crossed hemiplegia or uncrossed. Crossed it is brainstem. Facial nerve will be on one side, weakness will be on the other side. Next, the weakness, if it an anterior circulation, which artery is involved? Differential weakness or same weakness, up and above. Differential, it is cortex. Equal weakness, it is subcortex. If cortex, there are two arteries, anterior cerebral and middle cerebral. Anterior cerebral, leg is more involved. Middle cerebral, upper limb is more involved. Internal capsule, both are equally involved. One more point is dense hemiplegia will be there. That is mostly 0/5 power. This is seen mostly in internal capsule only. Then thrombotic or embolic. This is what you have to discuss based on the history, how it evolved. These are the things you should say and finally conclude it. Stepwise arrival to the diagnosis will impress the examiner. Don't say it outright as a CVA, stroke, sir. Then you will be in soup. They'll ask you who told you the diagnosis. There's no terms like new, old. You can choose whatever you want. Stroke will be convenient. MCA, upper limb is more compared to lower limbs. So we have come to the end of the session. Any doubts? Central versus peripheral nystagmus. Central is due to your brainstem involvement, cerebellum. Peripheral is due to your vestibular nerve involvement. It has quite a lot of points, which will be very difficult for you to take it at an MBBS level. I don't want to confuse for an exam when you're going for exam. So I'll try to avoid that. So many of you have been asking for a bilateral UMN and LMN 7th nerve palsy. Okay. I'll tell you about the bilateral UMN. The common variables you check for. Bell's phenomenon will not be seen in UMN. Long track signs will be seen. Corneal reflex will be normal in UMN. Emotional palsies is not seen. If you refer facial reflexes, it will be exaggerated. In LMN bilateral facial palsy, Bell's phenomenon will be seen. Corneal reflex will be absent. Emetic palsy can be seen. Long track signs may not be seen. Reflexes may not be present. Emotional facial palsy versus the central is when the patient smiles, talks to someone, she is subconsciously doing things, there will be no palsy. When you particularly ask the patient to smile voluntarily, getting their attention, then you will see the deviation. So the weakness is not present 24 hours. Only when they are being asked to do on insistence, you will find the weakness. That is emotional palsy. The reason is it does not pass through the internal capsule. It has a different way from the cortex to the 7th nerve nucleus. Long track signs na deep tendon human signs, deep tendon reflexes, weakness of limbs ella. Pseudobulbar palsy is bilateral 9, 10, 11, 12 involvement, usually because of bilateral frontal or corticospinal tract involvement. Pseudobulbar palsy is seen. Why the term pseudobulbar? Why bulbar is usually 9, 10, 11, 12, it is element type. But in a pseudobulbar, it is UMN type. Why it happens is bilateral corticospinal tract involvement. Where to look for clonus? Clonus can be seen in 3 places. One is ankle, another is patella, third is wrist. Young stroke below which age group? Keep changing the limits. As of now, it is less than 50. Importance of BP in what? Where? If you can be specific. Guess I have answered many of your questions and it's getting too late. I think we can finish the session. Should have been a 1 hour session, but a long case, it's very difficult to complete within 1 hour. Hope I have made some justice. Best of luck.
Yes, sir. Very thank you so much, sir. Thank you so much for this amazing session. It was worth spending for each and every minute here, sir. Such an informative and contentful session it is. Thank you so much, sir. And thank you so much for everyone who has participated in this meeting. It's almost at 11 p.m. There were more than 200 participants here. Thank you so much for everyone who have attended this meeting. Yeah, thank you so much, sir. Tomorrow we will have a medicine session on abdomen case discussion at 6:30 p.m. Once again, 6:30 p.m. Please note the timing. Thank you so much for joining. Thank you so much, sir. Thank you, everyone.